We're going to get started, and one of our panelists is going to come in a little bit later, and perhaps people will trickle in. But thank you all for being here. Welcome to our second event of the year, the link between public policy and public health. A piece of housekeeping, and Dennis, just say to make sure I get this right. The door that you came in case of an emergency, is the same door that you will go out. And should something go very wrong, Dennis will save us and lead us in the right direction, so find him. Thank you. My name's Maya Fernandez. I am a member of the IPAC NWT Regional Group Board and chair of the Events Committee. For those of you who don't know, the Institute of Public Administration of Canada, IPAC, was founded in 1947 and is committed to advancing excellence in public service through research, networking, and celebrating achievement in public administration. Our regional group was established in 2012 and is one of the largest ones in the country. We work to further IPAC's mission here in the NWT by holding informative and engaging events, such as the one that you are about to hear. Today we have an exceptional panel of speakers, and we're fortunate that the panel is anchored by a great moderator in Dr. Sara Cook. Dr. Cook has been a family doctor in Yellowknife for 8 years. She is the inaugural Territorial Medical Director of the Northwest Territories Health and Social Services Authority. Prior to this role, she was Medical Director of Yellowknife Health and Social Services Authority. In 2015, she was the recipient of the Premier's Award of Individual Excellence and the Award for Leadership Excellence in Healthcare from the Northwest Territories Medical Association. 2015 was a good year. I'll pass it off to Dr. Cook to moderate the panel moving forward, but perhaps we can give a warm welcome to everyone here.
Thank you very much, Maya, for the introduction and for organizing this event. I'm excited to have a great panel here, and hopefully our last panel member will be joining us shortly. So my role here today is to briefly set the stage and then to moderate the discussion that follows. I just want to get a sense first of who is in the room. Are there any healthcare providers here? One. How about people that are working in health policy? You? Okay, so everyone else is working in some other domain, so that's great. So we have a mix of people. That's interesting. So as you know, our topic today is the link between public health and public policy, particularly in the northern context. Before I introduce our panelists, I think it'll be helpful to define some of the terminology we'll be using. So most of you, I think, are probably public administrators, so I don't really need to define public policy, but maybe since the majority of our panel are not public administrators, I'll define it anyway. So while there are many definitions, I understand that it's basically defined as a course of action adopted and pursued by a government. Of course, there are innumerable public policies made by every government, and these include health policy, but also policy on such things as taxes, transportation, energy, trade, environment, culture, etc. And so what is public health? The definition cited by the World Health Organization is that it is the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. So what is the link between health policy and, public policy, what governments do, and public health, the incidence of disease and injury in the population? That's what we're here to learn about today. We've got an excellent set of panelists to address the question. So I'll start by introducing, from immediately on my right, Dr. André Corriveau is the Chief Public Health Officer for the Northwest Territories. He was appointed to this position in 2012. Dr. Corriveau was previously the Chief Medical Officer of Health in Alberta and also served as Chief Public Health Officer for the Northwest Territories from 1998 to 2009. Next to Dr. Corriveau is Ms. Sara Brown. Ms. Brown was raised in Yellowknife. She started out in construction and consulting, working with communities as clients. Sara took her first job as a municipal engineer and then SAO in Iqaluit almost 20 years ago. Sara has dealt with varied issues facing communities as a manager of engineering, director of public works, and bylaw with a number of communities throughout Ontario and Alberta. before returning to the Northwest Territories as SAO for Inuvik. She is now CEO of the Northwest Territories Association of Communities. And next to Sara is Dr. David Pontin. Dr. Pontin is an emergency physician at Stanton Territorial Hospital. He is the past president of the Northwest Territories Medical Association and continues to serve as an executive member. He is also the new Territorial Clinical Lead of Emergency and Hospital Services and Medical Education in the new Northwest Territories Health and Social Services Authority. And I think I'll introduce Courtney Hubbard in her absence so that you'll know who she is when she arrives from the dentist. She is an emergency physician, also at Stanton Territorial Hospital, and she's also a board member of the Canadian Association of Physicians for the Environment, or CAPE. In 2015, Dr. Howard presented a letter on behalf of more than 150 Canadian doctors and medical students to Canada's Minister of Environment and Climate Change at the COP21 conference in Paris, calling on the government to take action on climate change to protect the health of Canadians. So now to the discussion. So in terms of format, I'll invite the panelists to address each of 3 questions in turn. I'll try to manage the time and keep us on track. And we'll aim to have time for audience questions at the end. So if you can see your questions at the end, that would be great. So first, I'd like to explore the impact that our panelists' work has on health in the Northwest Territories. In medicine and in public health, we talk about health, but we also often talk about social determinants of health. These are non-medical things such as income, education, race, housing, and gender that affect people's health. So I would like each of you to describe, we'll start with Dr. Corriveau, your current role, and tell us how much influence you feel you have in that role on A, the health, and B, the social determinants of health of the population you serve.
Okay, well, thank you, Sara, and thank you for being here. It's really a pleasure for me to participate in this panel. Well, I think Sara already mentioned, I've been appointed as the Chief Public Health Officer. I've served in the NWT, and then I had an experience in Alberta as well. And one aspect of it is that under the Public Health Act, I'm delegated by the Assembly really to intervene in situations where there's an immediate threat to health and take direct action to protect the health of citizens. And usually it's more applied in the context of infectious disease outbreaks or threatened situations, and very occasionally in environmental issues where we could forbid the community to use a source of water that's become polluted or those kinds of things. But most of the time, my role is more of an advisor to government on issues that will impact on the health of people. So I, through the issuance of reports, recommendations, briefing notes to the minister, talking directly to them. I also have a role at the national level because we have a small group of people from the chief medical officers of each province and territory, and we have what's called the Council of Chief Medical Officers of Health that provides advice to the Conference of Deputy Ministers of Health across the country, and through that group directly to health ministers. So we can provide policy advice on various issues that affect Canadians, whether it's the obesity crisis across Canada or the fact that our food has too much salt in them, processed foods in Canada. So those are the kinds of things where we issue recommendations to health ministers as a collective and recommend the steps and things that can be done.
Thank you, Dr. Corriveau. Sara?
Thanks very much, and thank you for everybody for coming out today. It's really great to see this awesome group out. So I represent the NWT Association Communities, and we do advocacy work, but we also do member services and provide services to our communities. We represent the communities themselves are our members, and that includes the senior administrative officers and the senior staff, as well as elected officials. So we have lots of opportunity there as well. I'm going to provide some of my comments both in the context of our association, but also in the context of our members, because that's really where the links are. We just are facilitating those links. So we've certainly talked, we have a project actually with Dr. Corriveau's office called the Power Up Project, and it's around actually drafting and policy and practice recommendations for communities to adopt, and we're very excited because that's just being released. But one of the things we keep harkening back to is that municipalities often get forgotten in the mix because they're not obvious players, but they actually have a huge opportunity to influence outcomes of public health. The one example that we all absolutely take for granted is drinking water. That's huge. And it's one of the major determinant of general health and mortality in the world. And we really take it for granted that communities are doing that and looking after it. And so, you know, there's so much opportunity there, we think, for doing that. All of the communities in the NWT have community wellness plans, and they are very much made in the North solutions because they reflect their community and their community values. And so those are critical. And I think the other thing to remember as well, that it's not just policy. When you get down on grassroots like a community, it's also practice. And they certainly have opportunities to influence things like economic development, waste and wastewater, celebrations of culture on the land. One of the prime examples, again, we forget that they're doing this sometimes until it falls apart, is that community center goes offline for whatever reason, fire, needs repairs. The RCMP can tell you the justice impacts are huge. We have communities that we celebrate quite a bit, like in Clavic, that by having very, very active programming, they don't have impacts they have no kids in the justice system. It's pretty phenomenal. And you're talking about dealing with spirituality, physical health, all those things, so it's pretty critical. So there is a lot of opportunities to do that. And I look at Dr. Howard's work she presented to our AGM this year. I really appreciate her coming in to do that. But again, communities were becoming part of the solution in offering space for people to exercise inside. Those of you who are here in Yonge recall that there were announcements on the radio that you could come and exercise in various facilities. And so I think by using partnerships, there are so many opportunities for communities to be involved.
Thank you. So welcome, Courtney. So I did give your introduction already, so everyone's heard about your background and who you are. So we'll go to Dave next, but just to catch up, we're on the first question, which is around describing your current role and how much influence you have in that role on A, the health, and B, the social determinants of health of the population. So Dave, do you want to speak next?
Sure, thanks, Sarah. Hi, everybody. I really appreciate you coming out today. I'm seeing a lot of familiar faces out there. And it's nice to be talking in a group where I'm not just always talking to healthcare providers, because usually when we're talking in a group of healthcare providers, it's usually often talking to a group that's sort of preaching to the converted. So I hope we have some great discussion after this, and I'd be very curious to hear different understandings or ideas around some of the things we're going to talk about today. So thanks again for coming. So I am a full-time emergency physician at Stanton Hospital with my colleague Courtney here, and I've been there for 10 years. And so my full-time work really puts me, I suppose, in opposition to a certain extent where André is, sort of right smack in the front lines of dealing with all of the medical and health issues in the Northwest Territories and all of its wonderful diversity. And so in some ways, I think emergency departments and emergency room physicians are great people to talk to when you want to talk about public health, because we see where public health is falling apart or failing, and usually or often emergency departments are very important sentinel sites for emerging infectious disease, emerging injury patterns, issues and societal breakdown, and the end effects of persistent problems with our social determinants of health. And so we're going to be talking, I think, quite a bit today about social determinants of health. And these are, as Sara introduced, I think at the beginning, large societal factors that make huge disparities in the health outcomes of individuals. And so Courtney and I see that play out in our world on a day-to-day basis. So I have been, over my 10 years, a witness to the scourge of homelessness, poverty, alcohol and drug addiction, and a whole host of others in my day-to-day work. And part of that has then driven me out of the emergency department to places like the Medical Association, and most recently to the challenges of being involved at a territorial level with the territorial clinical lead of acute medicine as well as education, to be involved at a kind of more policy level, because I think actually after struggling for 10 years on the front lines, I think that's probably where a lot of our impacts can be made. And so I'm very excited about some of the opportunities that lay ahead for us as a territory in the coming years and months. The other area I just wanted to mention that I have been involved with, and is for the last 10 years I've also been involved with, Sara didn't mention this, but at North Slave Correctional. So I have a big understanding of the issues that plague our justice system and the health and psychiatric issues that are there. And frankly, one of the reasons that there's a nice, I find a nice kind of crossover with what I do in the emergency department is that those two worlds, the intersection between the emergency department and the problems in the justice department are virtually the same. And so I suppose I feel very, very at home in this correction. So I think, so two questions that Courtney asked, or it's not Courtney, but Sara asked were, how do I impact on the health of my patients in the emergency department? And kind of second level to that was, how do we impact on public health in our job? And I would say that emergency departments we're an acute fixed place. Everybody knows that. We often are in a situation where all we're doing is simply picking up the pieces for something that's already gone disastrously wrong. And sometimes those things that went disastrously wrong may have started when somebody was born, you know. And so, so I would say that our impact on health from a societal perspective is actually very, very small. But I think on an individual perspective, I think we can make huge impacts from time to time. And it depends what the kinds of problems are. So I guess impact on the individual can be quite large at times, depending on the acute care problem. But on the impact on public health, I would say probably emergency departments are pretty small. So I'll leave it at that and pass it over back to Sara.
Thank you, Dave. Courtney? Well, thanks, and I have to say, I'm just so happy that this panel is happening because it's all about, you know, the back and forth between the people who are in the hospitals and outside of the hospitals with diverse skill sets. Sorry, my husband's on call, so I should probably. Oh, that's okay. Not husband. Kids, so I'm gonna have to like run if there's a break. So. In medicine, people who care about health go into medicine, and you think you're going to emerge as someone who's like the expert in health, who can fix things, and you know you'll be like ready to really help your population with their health outcomes. And they didn't when I was going through, and I don't know if the same was true for you, but social determinants of health wasn't really a big part of my medical training. If you go through now, it's a much bigger part. But I went through, you know, learning about like chemistry and lab tests and X-rays, and thinking that was sort of really the majority part of health. So when I emerged as a fully trained emerge doc and saw the stat that what happens inside the healthcare system really only account for 15 to 20% of overall health outcomes, I don't know about you, but I was kind of choked. I was like, really? Well, why did I do that? And so, you know, you're like, okay, well now I'm an emerge doc and I'll do a good job at that. But as Dave said, I mean, we're really the place that people who have nowhere else to go come, you know, we don't fit into any other system. And so day after day, week after week, you do see, it helps you perceive the holes in the rest of the system. And when I look across Canada at physicians who are really active in advocacy, I would say emerge docs are disproportionately participating in that kind of work. And I think it's because you just end up so motivated from seeing, you know, the same things happen over and over. So I actually, you know, with my clinical work, I work half-time in the emergency department, and I basically have a unpaid half-time job doing environmental health work on behalf of the Canadian Association of Physicians for the Environment. And that works out well for my family because my husband is a full-time pediatrician, and there's no way we would ever have a Saturday off together if I tried to do more clinical work. So this way I'm busy and I'm, you know, I've been useful. And I got into that, I actually am very much sort of an anthropocentric person. You know, I did kinesiology as an undergrad. I really never would have considered myself an environmentalist, but right before coming here, I actually spent 6 months resuscitating malnourished children as part of a pediatric malnutrition project in the Horn of Africa. And that was very much using my emerge skill set, and you know, the kids were mostly septic, they had terrible pneumonia, and a lot of them died. And you know, these were displaced children who largely come from Ethiopia and Somalia, were in Djibouti at that point. And you know, there was just one moment where another child died, and I was filled with such like incredible white hot rage that I said to myself, well, when I get back home in a place where I speak the language, where I have, you know, more of an ability to actually get things done than I do here, I'm going to do everything I can to prevent this. And I think, you know, I think a lot of people have had a moment like that in their life where you just like decide something. And coming back here, it's so clear that climate change and health here is impacting our population, you know, and, you know, I see patients in the emerge, especially in the spring, who go through the ice and end up with like big lacerations or, you know, dangerously immersed. You know, the wildfire summer 2014 was a real sentinel for us. I'm still doing that research project. I'm actually presenting tomorrow to the National School Forum about that. And so I think so much of my work has just been about, okay, well, this is my skill set, this is where I am, how can I have the most impact? And so climate change is the biggest health threat of the 21st century, and, you know, that's what the WHO says now, and the Lancet tells us that working on climate change is our biggest health opportunity. You know, I'm all for working and putting energy and time into the biggest opportunity. And so that's why I do the work that I do with the Canadian Association of Physicians for the Environment. So basically, you know, I think that the goal is to have health in all policies approach. You know, every single policy that we do, whether it's about justice, whether it's about housing, whether it's about food, if we can communicate back and forth between the health community and the people with other skill sets, each of us recognizing that, you know, we're part of the puzzle, being humble within that. But also recognizing we have something to contribute. You know, I think that that's how we build a system that serves everybody as best as possible so that they don't end up in the emergency department.
Thank you. That is a great segue, Courtney, because we're going to shift gears and talk about the impact of public policy on health. So we'll start with Sara, and then we'll come to André, and then Courtney and Dave this time. So from your occupational perspective, what policy decisions could have the most positive impact on public health outcomes in the Northwest Territories?
Thanks very much. I'm actually going to echo what Dr. Howard just said about the importance of collaboration. We have a lot of different groups, government agencies who are all working on pieces of the puzzle, and we need to be making sure we're working in synergy together and we're supporting each other. I just look at the H1N1 piece that we had here, and that was a very collaborative process that the territorial government took, and through Dr. Corrivau's office, and that made a huge difference because in the community, I was in Inuvik at the time, we had resources and things that we could assist with, delivering it on the ground, and then we were often answering concerns and calls from the public, and we were better informed, and it was a really good example of where together we got so much more done. Certainly everything here should be really from the ground up as well. And that's where I think communities have an important role to play because they're delivering services on the ground, day to day, and I think that's really important. Also, although we have things to learn from other jurisdictions, we need to not be afraid of designing our own programs and designing our own approaches, because we are unique. We have a unique group of skill sets amongst our various partners, and so I think there's lots of opportunities to do that. And again, I would stress the collaboration piece is to use the networks we already have. Our public health project that we have with Health and Social Services and Dr. Corrivau's office is very much about, we already have a network with the communities. Why would you reinvent that? We already have a skill set, we have an understanding of how they do business, so we can translate that into something that's effective for the community. So that's definitely my thoughts on that.
Thank you.
Well, you know, obviously Dave and Courtney have already highlighted some of the, the issues that they see emerge, and Courtney has picked a topic that is certainly on a global scale is going to be a very important one for the world, and the world population perspective, and issues like war and displacement of people. But I'm going to take a more sort of a regional approach in the NWT in terms of, and so even here there's no shortage of issues that could benefit from a social determinants of rents. We have rates of STIs that are 10 times the national average. Injuries are twice the national average. You can just go on and on. But I think from my own perspective on things, and supported by actually quite a bit of research that has shown that an investment in early childhood, a dollar invested in early childhood is reaping benefits of 6 to 8 times. I kind of feel that this is where we need to, we have the greatest to benefit from. It's a lot of the issues that we deal with, even things physically like diabetes and obesity and high blood pressure in adulthood are linked often to impacts of early childhood events. So the 10 years strategic framework that was basically developed and produced in 2014 is really, in my view, one of the critical work areas for the government to influence the health and well-being of the next generation here in the Northwest Territories. And and because supporting early childhood requires that we support young parents, that we keep a focus on poverty issues, housing issues, and food security. It's an area that can bring in and requires a lot of partnerships with the community governments, with the federal government, with different parts of the territorial government as well. So I think we have an area that we have basically a 10-year framework and action plans that are being developed in partnership with others. That I've certainly been a strong advocate that we keep a focus on early child development and supporting parents succeed in raising healthy children, and that will have a huge impact down the road. The other area I think that for the territorial government that is also a national issue that was highlighted by the Truth and Reconciliation is the impacts that we have in our society of the residential school and the loss of culture that are linked to many of the mental health and addictions issues, family violence, the whole area around impacts of long-term impacts and intergenerational impacts of trauma. So I think another area that's very important that we can focus on is the support to rebuild the culture and the traditional values of Aboriginal communities. And so the on the land programs that were hinted at already is an area of, I think, a great importance because many people are working independently on the land programming, whether it's the justice people, the health people, the education people, and I think there's a way through the recently developed funders collaborative on the land programming that includes actually a number of charitable organizations that we can have a huge impact working in partnership with the Aboriginal governments to restore pride in culture and traditional knowledge that would have a huge long-term impact on our population here in the north. So that would be the other area that I would pick as my second favorite.
Thank you, André. Courtney? Sure. So I think that I'm assuming that Dave is going to talk about more emerge relevant stuff in terms of housing and that kind of stuff, so I'm going to leave that to you. Looking at resiliency up here in terms of climate change, I do a lot of work at the national level with CAPE, and most of that is on mitigation. So how do we, really decrease greenhouse gas emissions? Here, I do some of that work, but really we're way into adaptation, and so the thinking I do locally is more around that. So there's a few sort of small things, I think it's really important that we start to look, and they're already doing this at healthy energy supply, particularly really in the communities. The diesel is so expensive for us to bring in. There are some studies showing too that diesel smoke is, it's really no better than any other kind of smoke for people's lungs, and actually, it was actually shown by a prop at UBC to actually induce DNA changes in people's lungs and increase asthma. So, we don't need any more respiratory problems in the community. So certainly, there's a real health element to the energy choices that we make. And I know that just for even economic reasons, they're trying really hard to move away from diesel and move to, pretty big solar projects in the communities. And that's certainly something that we can speak to from a health perspective and, should be supporting. Water, as people have said, I actually had someone come into the Emerge, and this is totally unsubstantiated, but he was there because he'd fallen on the ice and broken his hip. And the reason he'd fallen on the ice and broken his hip is because his son had gone out, and it was around spring breakup, to get water from the river, and he got worried that his son had fallen in, and so was out looking for his son. And the reason his son was even out getting water from the river was because they were worried that the community's dump and sewage place was too close to the community's water supply, and that given the melting in the permafrost, the one was contaminating the other. And so his family had made the decision to just get water from the river. So, permafrost melt, I'm actually having to redo my foundation in my house right now. So I've read the geotech report, which actually said that average permafrost temperature in Yellowknife is now 0 degrees on a year-long basis. So that means that we're going from it used to be -1, which means that it was mostly frozen, and now it's kind of melted. And so that's going to cause changes that we have to anticipate in some of that. And actually, the studies, when you look at Health Canada, what they say we have to worry about in the north, part of it is actually contamination of water supply. And that was the first instance I'd ever heard of someone who's actually already worried about that. But, we have to keep our eye on that, because that, that's a thing. I also went recently, just on Tuesday, to the food security. They're having a big food security conference in town right now. And as it happened, on my way home, there was a CBC documentary on the decline of caribou, and we know, we hear from our patients, and we know that caribou stocks are declining. So how do we ensure food security in a changing environment, and ensure culturally appropriate food security in a changing environment, and ensure healthy food in a changing environment, Bishop London, I've seen her speak on this, and she was sort of saying, maybe we can't have caribou, but she was pulling it to the essence of it. The essence is independence. The essence is being able to control your own food supply. And she said, well, maybe that doesn't mean caribou, but maybe that means we learn how to have chickens. And that's not traditional food, but it echoes the traditional value, which is independence. And I thought that was really interesting. So how do we do that? Is it chickens? Is it when people come in, we're going to have this old hospital where the new hospital is. Do we have a place there where we teach people help them find new recipes, like, you know, lentils and beans. Like, beans are not a traditional food up here, but they're a traditional food of many other, you know, even Bene people. You know, and they keep well, and they're cheap, and, you know, like, that can be a really healthy food stuff. Is there a way to work with communities to find new things to eat that are healthy and reasonably priced and, you know, can be worked into the culture? Or, you know, how is that? Can we pull from traditional values of independence to seek new ways forward? And I'm not really the best voice or person to be figuring that out, but I'm really interested in that, because I think, you know, like, you know, if we turn from caribou to white flour, and we're gonna be in trouble, right? So what was our thinking long term? And something else I think is really important, you know, I'd really like, around the Truth and Reconciliation Commission, there were recommendations about incorporating Aboriginal healers into traditional medical systems, and we're starting to have conversations as a medical sort of community and our medical community about how to do that. And I think that in terms of public policy moving forward, I'm really interested to see how in the north we can start to do that. There's different initiatives across the country, you know, as a way of sort of decolonizing the actual, you know, medical service provision, and you know, helping our population really reconnect with their culture in a way that we know is healthy. So anyway, those are the things I'm thinking about right now locally.
Thank you, Courtney. Dave, you can finish off.
Thanks, Sara. How much time? Is
Uh,
it till 1 o'clock or 1:30?
Questions are going to be starting just before 1, so.
Okay.
But you have about 4 minutes for this question.
Okay. I first of all want to thank my fellow panelists. One of the things I just want to very quickly just is to thank André for what he's saying about early childhood intervention, because I do agree that I think that is a key problem. And we see how that plays out as people age and what that means to the system. I think we all do, frankly, by the time that someone who has had problems during the pregnancy, perhaps been exposed to alcohol in pregnancy, there may be some childhood neglect, followed by sort of things like early teen substance abuse, and then repeated head trauma, and then you add in issues of then homelessness, and then really heavy-duty alcohol use. And then what ends up happening is you've got an individual who is, for all intents and purposes, virtually kind of the best lens that I've used to understand these problems is severely disabled people, and all that comes with that. And so that supporting of our young has got to be a major priority to try to prevent a lot of these issues, because once you've got people in their 20s and 30s who have all of these multiple hits to their health and well-being, it's virtually impossible, I think, as a society to turn that around, frankly. So a couple things. So the question is impact of public policy on health, right? And so there are a number of things that have been brought up so far, but there's a couple of specific things I want to talk about that are really about health policy and legislation. And one of them is the sharing and the importance of sharing of health information, and how absolutely critical for emergency physicians that there is the ability to get pertinent health information with virtually no barrier as soon as possible. And I understand the concerns about confidentiality, and I understand all that part of it. But some of the administrative and legislative barriers, although it's a lot better than it used to be, to accessing somebody's crucial healthcare information in the world that Courtney and I work in, can lead to really bad outcomes. People can get really sick, or people can die without having the right information at the right time. And that includes getting information from other jurisdictions like Alberta. So that'd be a kind of a legislative policy piece that I think is really crucial for enhancing health on a kind of an acute way. The other thing I wanted to just briefly touch on, and there may be more room to talk about this later as well, is that in the North, one of the things that's quite unique about the North is the way that Courtney and I are hired. So Courtney and I are government of the Northwest Territories employees with everything that involves. And one of those things that involves is the contractual obligation, essentially that physicians have, our advocacy efforts are, and I don't mean to be, I don't know what to think, but are essentially controlled by the government of the Northwest Territories. And the problem is that sometimes the health of a community runs counter to the interests of to maybe the government of the day. And so it can potentially be a problem for our ability to be independently advocating on health issues and the interests of the government. So that's a policy issue that I think needs to be sorted out. Physicians need to have the ability to speak to public health issues, without the concern that it's going to impact on their employment in the Northwest Territories. So that's a sort of a real, again, a fairly narrow issue, but nevertheless an important one on health in the Northwest Territories. Now, on a kind of a larger societal issue, I'll just touch on it briefly, even though it's a massive topic. It's a massive topic for the people who normally sit in these chairs. And that's the topic of homelessness and addiction on the streets of Yellowknife. Our emergency department is a very, very expensive shelter during the winter months. There is just no question that what we're doing there is housing a lot of people through the winter months. Because they just simply have nowhere else to safely be. We have also a situation where homelessness tends to drive an enormous, these enormous healthcare burdens as a result. We've got ambulances that are being run off their feet because people are coming down to see us highly intoxicated or cold on the streets, or coming to the emergency department by ambulance. Who are then using emergency resources at a huge rate. And so one of the things that we're looking at in a fair amount of detail now is what we call emergency department super users. So these are people that are using the emergency department 50 to 100 times or more a year. In some cases, Courtney would know this, we're seeing patients, sometimes the same patient 3 times a day. And each time coming in by ambulance to a huge cost to the system. And so the homelessness issue is so costly on the healthcare side, so purely from an economic point of view, we need to start thinking about the impacts to businesses downtown and all that. We also have to understand the huge impacts on the healthcare system of not dealing with that problem. And then the other issue is just the human dignity issue. You know, like to constantly at 3 in the morning or 2 in the morning say, hey, listen, like we don't have a place for you here. Like you can't stay with us tonight, and having to look people in the face and discharge them from the hospital out into a cold night. I mean, it can be a very sort of dehumanizing situation when we don't have the ability within our community to safely provide for our homeless population here. And you know, when you look at proportionally the size of our homeless population compared to the rest of the country, we're way off the charts as far as the number of people compared to the number of people homeless compared to the size of our community. So this is a pressing issue for us as a community to try to solve, and it's not something that obviously I'm very motivated to do, but we can't do it on our own, and it's something I think every one of us in the room needs to think about how we're going to try to solve that problem.
Thank you. Another good segue, because now I want to talk about how. So we've heard now about the impacts of social determinants on health, and we've heard a bit about the impact of public policy on health outcomes. So now the question is how. So I think that this time we'll go to Dave again, and since Dave hasn't gone first, and then we'll go Courtney, André, and Sara. So the question is, from your perspective, how can we most effectively ensure that public health impacts are taken into account in public policy decision making? So just given we have not much time, how about like 3 minutes, 2.5 to 3 minutes each, and then we'll wrap up and take questions.
Keep it really short. The homelessness piece, we need more housing. and pathways from the street to stable housing. And so, just to keep it really brief, I think that's what we need.
Courtney? I mean, part of how I think is the system. And just speaking a little bit more to what Dave said, you know, the issue of physician independence and advocacy actually exists across the country, and it's big. Like the chief medical officer of health in Brunswick was actually recently fired. She was somebody who had been the first doc in the country to really do a proper report on fracking. And she was doing a report on glyphosate, which is Roundup, and then she was fired without cause. And so first she's fired, a few months later, she actually receives the highest award that her professional association can give in Canada. So this is not somebody who was not extremely well thought of, right? And that's because, you know, information sometimes is threatening to power. And so, you know, in BC, for instance, the public health docs there were also terrified to take on fracking based on what's happened in other places. And so, something that docs who are not public health physicians can do, or can try to do in other places, is support public health docs to create a space where they be like, look, the evidence, like for instance, 80% of the studies on fracking that have ever been published have been published in the last 3 years. So the evidence base has completely been overhauled, and over 80% of the ones that have been done on health show a problem. So doctors in BC were coming to me saying, Courtney, like, I'm worried I'm gonna get fired if I do this. So we did a big open letter saying, look, we need health impact assessments for all fracking projects. It was signed by hundreds of doctors in BC as well as the Public Health Association. And I can do that elsewhere, but I couldn't do that here. So we need to find a way to, and I suspect that there are people in other disciplines who are similarly tied. So I think that we need to be able to find a way to have our contracts be written such that we can actually harvest the information and the knowledge that's in our communities. It doesn't benefit our population. I mean, are we here to benefit the population, or are we here to benefit the people in power, right? And I think that we need to, like Sarah's actually doing an awesome job of really trying to take a look and create a policy that will allow physicians to speak freely here. And I would encourage all other disciplines to really take a look at, you know, what are your rules around that, and are they being over-enforced? Because I think that's happened within our area. And how can really explicit policies be put forward to make sure that the people who know what they're doing can freely speak to the benefit of the people that we're all trying to serve. So I think that's a really important how.
Thank you. André?
Well, I'm going to echo some things that have already been said, but I think first of all, we need the data. So we need to have a good research infrastructure to provide, and then the analytical capacity, so that, you know, data flow, because you can't make good policy decisions if you don't have the evidence to support it. So that's, for me, is a critical aspect that's often neglected. It's the first thing that's cut when there's, you know, the budget crunch in the government. You know, that's the piece that goes first, because there's no immediacy to that service. The other one is at the other extreme, is that every policy decision ends up being made in a political context, and political context is influenced by public opinion. So you need to have public discourse on these issues. So you need to have forums or opportunities to have, you know, I don't like the term public education, because in a way it's a dialogue, but you need to have the forums for issues to be discussed at the public level, so that they can influence their politicians, who can then make the policy decisions. So there's like the two ends. You need the research and the data, then you need forums to discuss them, to make the evidence widely known and available, and have people talk about it in their homes and in their, and then you know, the thing will come together. And that's where good policy shouldn't get made, is when the two coalesce somehow, and you have that synergy. So that's my little 2 cents worth to that.
Thank you, André. And Sarah, you get to close. I get to close. Well, I'm going to reiterate what I said before a little bit. Sometimes we forget about municipalities as decision makers and practice, important parts of practice as well. And that they need to be supported in doing that, and that a lot of what's been discussed here is the front end piece, but then what happens when it's time to deliver and how can we do that translation for them to take it from either academia or facts and make it into things being delivered on the ground. And then again, just to reiterate the strong collaborative networks, and you know, certainly we're engaging within the NWT, and we need to engage outside too, and everybody has all these different networks, and we sometimes forget to take advantage of.
Thank you so much. I find this topic fascinating, of course, and it's really fundamentally important, the link between public health and public policy. You know, that they're very intricately linked, and I think that our challenge is to make sure that that link is really productive, and that we ensure that the insights of health professionals inform public policy, and also that intelligent public policy advances public health. So I thank you all very much for your comments, and we'll open it up for questions. I'll just ask, because this is being recorded, if people can come to the microphone so we can hear and record the question.
Hi, thanks. Thanks, everyone. My question kind of relates to, I guess, the how. I think it could be argued that everybody is in agreement that the social determinants of health have great impact on health outcomes. I think that the literature suggests that implementing a social determinants of health approach is much more difficult. And we heard a lot about a health and all policies approach, which yes, would be great, but I think that some of the pushback we get is that then we're viewing health as the center of the world, which a lot of us are fine with, but other departments would perhaps disagree. And so the idea on the ground, when you're, perhaps for a simplistic example, is investments are going to go into other departments and savings is going to come out of health. And so when we're all working within our silos in that respect, I guess I'm looking for your thoughts on how is it that we truly implement a determinants of health approach when you're coming from the really nitty-gritty cost and mandates of a policy and a siloed policy perspective. Is it that there's been other jurisdictions that have implemented kind of a human services or something department that is a lot more interdepartmental and a lot more collaborative from the get-go? We've seen small pilots that work within a social determinants of health approach because from the get-go, everyone essentially puts in the same amounts of money, if we want to talk dollars, and then this thing gets implemented. But when we're looking at a systems approach, I think that that's a hiccup that no one's really talked about in regards to how that social determinants of health approach works when benefits are going to come to one, let's say, department or budget, and you know the investment needs to come from another. So homelessness would be a perfect example of that. So that's my question to you.
Before you sit down, do you mind introducing yourself?
Oh yeah, my name is Katie Sudoreco. Thank you.
Would anybody like to start with this? Dave? Yeah.
I don't. Thanks for your question. I mean, I'm obviously an emergency room doctor, so what do I know about the policy world? But one of the things that a few years ago I was at the Canadian Medical Association AGM, and they had the theme of the AGM was determinants of health, and they were talking about this problem. And one of the ways that Norway, for example, has dealt with this issue is created kind of basically a policy lens. I mean, and I know these are already out there in extent, but using the idea in Norway, I don't mean to offend everybody, but the idea in Norway was that everybody was a health minister or in the Department of Health, and so that every policy was looked at through the lens of how is this going to impact human health? What are its impacts? Is this going to be, if we cut back in a certain area, you know, we're going to I don't know, certain cutbacks that are going to make a bunch of people homeless, or not homeless but jobless. What's that going to do to health? And how's that going to have to increase our health budget because of the downstream effects of making certain cutbacks, you know? And so every single major policy that the government of the Northwest Territories does is through the lens of, it's passed through the lens of a sort of social determinants on health type policy lens. And so I don't know, that's just one thing that kind of popped to mind. The other thing that on specific things like the homelessness issue, as an example, again, there's many people in this room who I've sat at similar panels like this and talked about homelessness issues. You and I have been on. There is no new ideas there. These ideas have been around for a long time. We know what we need to do. The problem is it is intra-jurisdictional, and there is a lack of centralized leadership, in my opinion, to just move forward on ideas that are out there already. And so it takes an enormous risk on certain people's part to step into that leadership gap and say, okay, it's on me. We're taking this forward. And it's pretty clear what needs to be done. We're going to take some risks and try it. So it takes, I think, focus and risk with certain issues that have been with us for a long period of time. But in Yellowknife, we will continue to be talking about homelessness and be vexed with this issue because it does fall between all these silos you're talking about. And I don't know where that leadership is going to come from, but someone at some level is just going to have to stand up and say, okay, it's on me and I'm taking it forward.
I think that another important part is doing what you're starting to do in the Emerge and just putting numbers on it. You know, it's hard to talk about benefit. Like if the benefit comes to health and the cost comes from someone else, but you don't even know what that cost is. You know, you're one step back from it, you know what the numbers are. You know, because once you know what the numbers are, say we figure out that, you know, we're spending X million dollars per year on our super users, you know, maybe we get in touch with the people in the other disciplines who are also working on it, go sit around the table and go like, look, these are the extra millions of dollars health is spending on this. Maybe if we can all work together, we can then take that pot and divvy it up for next year in everybody else's budgets. Like, figure out a way to redistribute the financial benefits of the healthcare savings. And there's actually, like, the New Zealand, interesting things have been done around that. Like, when it comes to active transport, that's another place where, you know, investing in transit infrastructure and like walking paths and cycling infrastructure has tons of benefits for health. Like, it actually reduces mortality to cycle. But again, the benefits are to health and the cost is to, you know, municipalities. Well, the New Zealand Land Transport Agency actually costed out every single kilometer cycled and every single kilometer walked. It's something like 7 cents savings per health per kilometer walked and 14 cents per kilometer cycled. It might be slightly off, but it's tangible. And so now when they make new infrastructure, they calculate like how many people traverse that, how many kilometers it is. They actually put a number on it. And so they have the ability to then redistribute those to the different places who've been involved. And I would love to, you know, I think putting numbers on things makes things transferable. And so that's data collection, and I think that's important.
Sara? Just wanted to follow up on the thought about the applicability, the impacts in other areas. I know that Justice, for example, has a list of super users too. And I heard a stat from the RCMP in Nunavut that said that they figured that 8 to 10 individuals or households were eating up 50% of their resources. So can you imagine what the impact could be? And these were mostly people that they felt actually needed to be dealt with in other systems, but they default to Justice because much like health too, that you know, they could get those dealt with in an appropriate manner as opposed to, you know, putting people up by like all those things that would be huge impact.
Yeah, well, I think it just reinforces my view that we don't spend enough in the research piece and the data and the knowledge translation and making sure that that information goes back to communities. There's also, I think for me, a principle that, you know, although we have to think globally, we have to always, you know, the best actions are the local ones. And so, you know, those partnerships with the community government, with parents themselves, with the schools, is where we can achieve major impacts if it's done the right way. And so I think that's another piece of the how is making sure that we're not trying to do it on our own, but we're involving the people that need to be involved as locally as possible. And you made reference to the community wellness plans, but that's a great sort of launching pad for a lot of actions, because you can say, well, if you're aware, even as a physician, of this, let's say you're the responsible physician for a clinic and you know their community wellness plan, you can say, okay, how can I participate in this or contribute to it, versus instead of worrying about your own piece by yourself in your corner. So I think that's an important way forward. And of course, educating our politicians.
Hi, Curtis Moffat. Well, I've thought of several things while you were talking because it's such a dear topic. But one of the things, and it affects the homelessness population and so many people in the north, is alcoholism. And I know you were on the radio recently, Dave, talking about some harm reduction program. And I think, you know, obviously even with the violence study that we're doing, alcoholism plays such a huge part. So I'm just wondering if you could talk a little bit more about that to us, and if there's any progress been made, and maybe just thinking about it as a whole.
Yeah. I don't know if you guys have been to the dump lately, but they're pulling down the detox center, and so all of the pieces of that beautiful building out there are currently going into the landfill out there. And so for me, I mean, it's kind of symbolic, I think, of where we are with our the way we manage alcohol in the north. It is a symptom and a cause of many of the determinants of health that drive these issues, and it is by far and away our biggest addiction issue, by far. And I think that there's lots of us that work in this field for a long time. They get quite discouraged, you know, by this problem because it just seems that nothing seems to work, or you make 2 steps forward and come 1 step back. But I guess my message today would be, I think there is lots to do. I'm optimistic that we can make change. I think that there is certainly lots structurally within our world, within the health world, that I think are going to help a lot down the line with how we manage alcohol issues. It has been a stated priority of the government for decades, we know that. But I really think that that there is some, I think there are leaders stepping up in our community. Certainly, I just had a quick look at the plan that recently came out of the municipality here, and in cooperation with the health director. I can't remember all of the sponsors that were on that, but part of that was a managed alcohol program. I think that when we're talking about alcohol and alcohol problems, we're talking about a multi-pronged type of approach because everybody's needs are a little bit different. We have to support, clearly, the things that are being done well out there already. I mean, truly, night after night after night, the organizations that are holding this town together, like the Salvation Army, the great work that's being done at the Tree of Peace, all these people, like, they need to be supported, and then their approach needs to be augmented with things like potentially a managed alcohol program for those individuals who just simply can't stop drinking. So I certainly don't have all the answers, Curtis. But I think that just like there needs to be a roadmap of someone from homelessness to housed, there needs to be a clearly signposted roadmap from those who are addicted to wellness, right? And I think that we have pieces of that puzzle, but there are clearly gaps in that I'm optimistic are being looked at and slowly filled.
Yeah, I'm just thinking one little addition about that. You know, we have the new hospital being built. And did you just hear recently on the news, maybe it wasn't on the news, it was on a conference call that I was talking about with Sue Lookout. And they actually, when they have pregnant moms and dads come in, they have a kind of a public health promotion kind of unit in their hospital where they can actually, it's a great place for new moms to go and fathers. They can get their high school, place for them to go where they can be, you can deliver programs. And I'm just thinking, isn't this an opportunity for us? We're building a new hospital, and why couldn't we do something like that? And they're actually changing their numbers in Northern Ontario in terms of education and So I think I think it's really hopeful. I think there's a lot of things we can do. And I think people sitting in this chamber actually talked about changing the alcohol, the way that we distribute alcohol in our outlets. You can go in there any day and see the Mickeys, the vodka, go out to bootleggers. We know that they're moving. Why do we allow that? When in the southern outlets, they have to have a license or a piece of paper or something. There's a party happening, you know, to be able to take large quantities of Mickey's or vodka or whatever it is that they're getting. So I think we need to really be on to this. So.
Thank you, Curtis. Does anyone have any other comments before we go to the next question?
Hi, I'd like to commend the whole panel for all your discussion around public health and how it can affect policy. My name is Cheryl Case. I'm president for the NWT, Nunavut Public Health Association. And your topics certainly fit into a lot of the work that we strive to do in our nonprofit organization. The question I want to give to you is, what do you think that nonprofit organizations can do to influence policy as it pertains to public health?
Would you like to take that, André?
Well, I can start. Well, first of all, I think, you know, that I'll acknowledge I'm a member of the association, but you know, this issue that was raised by Courtney and Dave around the ability to speak up. You know, we can, through our membership in those NGOs, voice concerns that we might not be able to voice the same way in a public forum as individual professionals. But we have, through the association, we can pass motions, we can bring issues to the forefront. We do it in the CMA as well and other forums. So that's sort of an avenue to for us. And I think because they have the ability to speak independently, you know, that to me that would be an important aspect of their role, besides keeping their members informed and, you know, providing support for continued education on various topics.
Yeah, I just want to say a hearty yes to that statement. Yeah, and that's how it's sort of starting to be solved in other provinces. I mean, we are sort of additionally burdened with that issue because in other provinces it's only the public health docs who have the trouble speaking, whereas the physicians are independent. So here it's all of us. So, you know, we need to, you know, the medical association, the Northwest Territories Medical Association, as well as the Public Health Association, need to become more active from an advocacy standpoint. Yeah, and buddies too, actually, it's true. Yeah, I think I spoke at your AGM. Yeah, last year.
And the Association of Communities.
Yeah, and but yeah, we should probably have a meeting with you to sort of, because I think that there's, I do think it is really important to address the contractual issue, because I worry about, like, as a, you know, right now I'm a doc, I'm married to a doctor. If I lost my job, I'd be okay, I could still pay my mortgage. I worry about, you know, nurses who may be the only healthcare providers in our remote communities, and they're bound by those same things. Like, what do they do? What if they're a single mom, you know, and they come across something? So I don't think it's enough to have a public health. I don't think that can be our only outlet. I think it needs to be part of the actual contract and expectations and ethics of our what's written into what employs us. But I do think that in sort of as a stopgap measure, that's certainly helpful.
Any other comments? Are there any other questions?
Scribbling notes, I don't want to. So my name is Jillian Adams, and thank you guys again for this panel. And when I saw this IPAC, good job. It's like my dream panel, so this is great. My question is what are your opinions, or what do you see as the risks or the opportunities around having some of these outside or private partnerships coming in for very specific reasons, whether it's pilot programs? We saw our iPads with some of our early childhood, we saw this baby box program they're doing now over Nunavut, On a larger scale, the Funders Collaborative, around our On the Land, healing training. What do you guys think just in terms of opinions or risks or opportunities there? Because I think that that's something where we're seeing policies going into. We're trying to leverage some of our responsible corporate citizens and our businesses. And what do you guys think are the best ways to do that?
Would you like to? Well, I think that for those, I mean, the risk is that the evidence or the public health, thrust gets diluted in, a profit-making or a spin sort of element of the program. And I think, for me, we as, healthcare practitioners, other people who are working to optimize health, like within your sphere, it's up to us to sort of like be the bottom line. Be like, if you're seeing the actual program geared towards something that's no longer evidence-based, that no longer seems to serve the patient or, the precautionary principle or whatever aspect, to just have the courage to just say no. I think probably given resource limitations, it's necessary to at least consider them and see where they're going. But it could veer that way or it could veer that way, and to not be intimidated by the other partner, to not be intimidated by the possibility of losing the money, which is, I think, sometimes the thing, and to just really have clear thoughts about what an acceptable outcome is, and if it starts to veer away from that, to just say, thanks for your time, but I don't think this is going to work out.
I would echo what Courtney's saying. The one thing I would say is that as physicians, we are no strangers with having to deal with industry. In the Northwest Territories, frankly, we're shielded from a lot of the industry pressures that our Southern colleagues have to face. And what I'm talking about there is the pressure from pharmaceutical companies, right? Pharmaceutical companies show up constantly at physicians' offices and places of work with all kinds of freebies, and so and with offers to sponsor conferences and do all kinds of great things for the medical world, and at first blush looks like it's a good thing for our patients because, hey, I can give you the newest medication that's just hot off the press for migraine, right? Because I've just been given to it free by whoever. And so that has been a major issue that physicians have had to sort out. And I think that I would say that there are major risks with those types of partnerships, and I would think that there are some benefits there, okay? It's not that it's all bad. There are some benefits there, but I think as a territory, if this is becoming an increasing issue on a whole bunch of different fronts, that there has to be, the thing that's helped with physicians is very, very clear guidelines about what would be acceptable industry behavior and how it's vetted, and it's the RFP process and everything else that the GNWT would go through is a kind of way to protect against that. But just make sure that in those types of partnerships, while it may solve the short-term problem, that you understand what the long-term agenda is, that there's clear guidelines within the GNWT to manage those relationships.
Any other comments? I just want to add that with regards to the pharmaceutical industry, we have not sorted it out in medicine. The Canadian College of Family Physicians, for instance, commissioned a major report that said, actually what you're doing is really problematic, and they haven't acted on it. If you go to our conferences, Pfizer is usually bigger than the Canadian College of Family Physicians. It's a huge problem, and yes, I would be cautious taking more steps down that pathway. It isn't to say like a hard no, but like real caution.
Yeah, I'll just add, I don't have a lot to add on this, but it's really not all one or the other, but there's really some cautions, and guidelines are important, but I don't think there's anything wrong, for example, for diamond mines that have contributed to our pool or building of an infrastructure in the community, and have their added recognized that way. But there's obviously more often than not there's conflicts of interest or concerns about what is actually being said or done, or if they have an influence on decisions versus just contributing funding to a project. It makes a big difference. So those guidelines are critical.
We have time for maybe one, possibly two more questions. Are there any other questions, comments?
It's probably better for my health to stand up and go there, but I'll just stay here. So all of you have kind of touched on this in a very forward-thinking way, but I'm wondering if, given all of the linkages that are starting to show up very strongly between health and other factors in other areas, if anyone has an example of a program that has been influenced through a policy that was developed with all of this knowledge and linkages in mind that has proven very successful, and how did you measure that success?
I have one that would be worth looking up. A relatively local example. I don't know all the details of it, but it's one called Arch, and it crosses into the emerge world. But what Arch is, it's a way of hooking up homeless and addicted patients in a very innovative way with communities. And so what the Royal Alex has done is they've created this program where if someone comes in and they're identified during their emergency department stay as having, yes, to deal with a broken bone or whatever, but they also have homelessness or addictions issues, the next day they're booked with the Arch program. And when they meet with the Arch program, who they're meeting with are people that are dealing with making sure they have a social insurance number, making sure they have their ID, figuring out what housing is available. They're figuring out how to contact their family members. It tends to touch mostly on a lot of other health and allied healthcare related fields, but it does it in a way where all those services are sitting in the same, virtually the same room, sorting out how to best plug this person back into the system in a safe way to keep them out of the ER world. And that one was just one that popped into my mind when you mentioned that. It doesn't necessarily cross all that much, although one local example, frankly, now that I think about it, is the case management that our Justice Department has been piloting and working with. I mean, that's a great example of justice doing case management that crosses over both departments in order to advocate for their clients, who are also our patients, in I think a very highly innovative way. We've essentially got the Justice Department being very, very proactive in how they manage the health issues of their clients, and so and their housing issues, and their just the day-to-day issues about where their ID is and all that stuff that's key to accessing any kind of service. Right?
And I might add the whole housing first initiatives, not just here but in many parts, are very evidence-based, and they, a lot of it stems from looking at the super users and finding out. There was a seminal article in the New York Times, I think, about 20 years ago, called $1 Million Murray, and if you can Google it, you'll find it's a fascinating piece of writing journalism, but they basically did that, documenting this one person in New York City who was basically consuming $1 million a year of healthcare services, and it made the case by itself for why you had to rethink the whole approach to people who were homeless. So I highly encourage you to, if you never read this article, just go and find it. It's fascinating.
Okay, there's time for one last question. Any burning last questions or comments? Nobody wants to be the last. Okay, well, thank you very much for your attention and time.
I really appreciated the comment that this was your dream panel. We're always trying to make dreams come true, so happy that could happen today. It's an IPAC tradition to give our panelists a book related to the topic at hand, so we have those to give out, but just one more time to give a really fantastic panel a round of applause.